Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode features expert insights on addressing age-related comorbidities among people living with HIV. This episode is part of a larger educational program entitled Confronting Real-World Challenges in HIV Care. During this podcast, Dr. Daniel Kuritzkes from Boston and Dr. Christian Ramers from San Diego will provide a case-based discussion addressing comorbidity management and antiretroviral therapy selection for aging patients with HIV, specifically addressing HIV treatment-associated bone loss, cardiovascular disease risk, and HIV-associated neurocognitive disorders. For more information on Dr. Kuritzkes and Dr. Ramers, and for a link to the complete program, including a downloadable slide set, please visit the show notes for this episode. Now let's get started and hear what Dr. Kuritzkes and Dr. Ramers have to say on this important topic.
Our agenda today is going to go through three complicated cases, one that has bone and renal considerations, one that has cardiovascular complications, and then a third case with mental health and neurocognitive disorders. And hopefully we'll have time for questions and answers after we do each of these three cases. So the first case that I'll go through is one that has bone and renal considerations. This is a 63-year-old woman who's been receiving the fixed-dose combination of efavirenz, emtricitabine, and the TDF formulation of tenofovir for quite some time. She's been on this regimen since diagnosed 13 years ago, and she's done quite well with it. Her viral load has been consistently below the limits of detection, now less than 20 copies per mil by current assays. She never had any history of AIDS or HIV-related complications. Her CD4 nadir was just below 300, as you can see on the right there, and her current CD4 count is in the mid-600s. She does have borderline systolic hypertension. She has some impaired renal function with a decreased creatinine clearance and has got moderate proteinuria by dipstick, and also has some early evidence for osteoporosis with a T-score of minus 2.1 by DEXA. In addition, she's been experiencing some mild sleep disturbance on her current regimen, and her long-term internist, who had originally prescribed this regimen for her, has retired, and you've been asked to take over her care. If you were going to change her regimen, which of the following would you select? A fixed-dose combination with bictegravir and FTC-TAF, an alternative three-drug regimen of doravirine with 3-TC and TDF, two-drug regimens with either dolutegravir 3-TC or dolutegravir rilpivirine, a different three-drug regimen of rilpivirine with FTC-TAF, or something else. Each of the regimens that was listed as a choice has data showing that switching to that regimen is really non-inferior to remaining on whatever current regimen patients might have been on. I'm not going to go through each one of these in detail, but clearly for the fixed-dose bictegravir, the doravirine, and the various rilpivirine, and also the two-drug regimens, there were really outstanding rates of maintained viral suppression over the course of 48 weeks, and several of these studies also have 96-week follow-up data. Now, what might some of the advantages of switches be? In the Drive Ahead study that compared first-line regimens of efavirenz or doravirine-based fixed-dose combinations, you can see that the occurrence of neurologic side effects was substantially less in the doravirine regimen, and as we've seen in a number of switch studies from efavirenz regimens to alternative regimens, when efavirenz is discontinued, neurologic side effects have tended to diminish. The TANGO study was a study that switched from a three-drug regimen to a two-drug regimen of dolutegravir 3-TC. People on the three-drug regimen were receiving TAF-based regimens rather than TDF-based regimens. And what you can see is, as expected with dolutegravir, there was a modest increase in serum creatinine due to inhibition of tubular secretion of creatinine, which led to a proportionate modest decrease in the estimated GFR, but there were really comparable levels of urine parameters of tubular function, looking at the retinal binding protein to creatinine ratio and beta-2 microglobulin to creatinine ratio and the overall protein creatinine ratio. And then if we look at markers of bone turnover, you can see that there was a significantly greater increase in the procollagen terminal propeptide, which is a marker of bone synthesis in those who went to the 2-drug regimen compared to staying on a 3-drug regimen. There were also statistically significant but very tiny differences in osteocalcin and in type 1 collagen C telopeptide. In other studies that looked at a change from TDF or where TDF was discontinued, and remember that our patient has been on a TDF-based regimen. So, for example, the SWORD study, where patients either continued on their TDF-containing regimens, 73% or so of the people in these trials were on a TDF-containing regimen and switched to dolutegravir rilpivirine instead. There were decreases in bone-specific alkaline phosphatase. Here, the darker colored bars represent the change at week 48 compared to baseline. Improvements in osteocalcin, in type 1, the procollagen polypeptide, and in the type 1 collagen telopeptide as well. Of course, many of the phase 3 trials that are done for registrational purposes often enroll relatively small numbers of women. And so the study 1961 was done with bictegravir FTC TAF, particularly to examine the impact of switching to this regimen from whatever regimen people were on. This was either boosted elvitegravir or boosted atazanavir in a study that was done internationally, including in many resource-limited settings. And Sissi Kitio, who's an investigator from Sub-Saharan Africa, was the lead investigator on this study. And this study here, again, showed the benefits in terms of the both tubular function. That showed the benefits of in terms of tubular function of switching to a TAF-containing regimen with bictegravir. Here you can see the differences for those who were receiving TDF at baseline versus those who were not receiving TDF at baseline on the left and right hand parts of your screen, respectively. And again, looking more specifically at what happens in people who switch off of a TDF regimen, the two studies shown on this slide were done in people who were already receiving a rilpivirine containing regimen or were receiving a fixed dose efavirenz regimen with TDF, and they switched to the TAF co-formulation of rilpivirine with FTC. And in both studies, you can see that there were substantial improvements in bone mineral density at the hip and the spine. So in aggregate, we can say, looking across all of these studies, that when people switched off of a TDF-containing regimen, either to TAF or to a regimen that didn't include tenofovir, there were improvements in bone mineral density, and likewise, there were improvements in markers of renal tubular function. Well, let's make this a little bit more complicated. What if the patient was also receiving omeprazole for gastroesophageal reflux? Would that change the kind of regimen that you might consider for her? The use of omeprazole and other PPIs with rilpivirine is contraindicated because it interferes with absorption of rilpivirine. And so non-rilpivirine containing regimens would be an appropriate choice for this woman if she was being treated for GERD with omeprazole. So take-home messages for this case are that multiple options are available, and switching regimens to reduce toxicity, there are ample data from large clinical trials demonstrating non-inferior virologic efficacy of diverse switch regimens, as I showed you on the overview slide. And this allows for individualization of regimen choice based on patient need. In addition, two-drug regimens offer a newer potential way to reduce toxicity and are emerging as an acceptable strategy. So with that, let me turn this over now to Dr. Christian Reimers, who will take us through the next two cases.
Great, thanks, Dan. Thanks for that case. And I think it's a situation we confront very commonly in clinical practice as a patient on an older regimen who may or may not want to switch. And I think it's really our duty to be looking for the long-term picture now. This is what we're here to talk about. So we're going to move into the second case, and I'm going to address cardiovascular complications. So this is a 57-year-old white male who's receiving darunavir boosted with cobicistat, as well as FTC and TDF. He was diagnosed in 2008 with an initial HIV RNA of 78,000 copies and a CD4 cell count nadir of 190 cells. He started a boosted PI regimen, from what you can tell from the notes, due to concerns regarding adherence. He smokes 1 pack of cigarettes per day and has so for about 35 years, so 35 pack years. And he takes no concurrent medications. Over on the right-hand side of the slide, you can see some of his initial lab values there. A lipid panel shows a total cholesterol of 243, an LDL of 159, an HDL of 31. His hemoglobin A1C is slightly elevated at 5.9. Blood pressure relatively well controlled, 129/86. And using all the information that you have on the slide, we've calculated there for you a 10-year ASCVD risk score, and that's 20.6. Based on the current lab results and the clinical situation that you see, would you change his long-term ART regimen? Let me pull my partner here. Dan, would you change the regimen for this particular patient?
Yes, I would.
Yeah, okay. So we'll move on to the next question. If you decided to modify the regimen, which of the following regimens would you select? A, atazanavir boosted with cobicistat plus FTC and TAF. B, bictegravir, emtricitabine and TAF. C, dolutegravir, rilpivirine. D, raltegravir plus FTC and TAF. E, rilpivirine, FTC and TAF, or F, something else.
Either of the two rilpivirine regimens would be appropriate. I always worry a little bit about the dietary issues and drug-drug interactions, especially in people who have other comorbidities, and for the same reason would be a little less keen on using a boosted protease inhibitor here, especially because it would then be a two-tablet regimen as well.
Great. Thanks. So we're going to get into a little bit of the details of cardiovascular disease. Before we do that, I just wanted to make an overall point, especially for those HIV treaters in the audience that are kind of newer treaters. We started the first case with an example of a longtime HIV provider retiring, and I think we're going to see that more and more. And I think it's important to understand the historical context of ART through the years. So, for example, this patient was started on darunavir at a time when darunavir was probably in the first-line suggested regimens from the DHHS guidelines, and it actually currently is not. So sometimes it's worthwhile digging a little bit to see why a patient is put on a particular regimen and to understand why that regimen was selected. I'll also point out that back when it was first approved in 2006, darunavir came out as a BID regimen with 200 milligrams of ritonavir in it. And it wasn't until 2008 that the once-daily darunavir formulation was really recommended. So let's move to talk about cardiovascular disease in the HIV population in general. There have been many studies showing an elevated cardiovascular risk profile in patients living with HIV, and here's just one of them. This is from the NA Accord study, really a cohort of cohorts throughout North America. And what you can see on the graph on the left is the incidence rate of myocardial infarction by age strata, less than 40 years all the way up to greater than 60 years. And data is derived from the general population that does not have HIV in orange. And then people living with HIV, you can see at really every time point here from 40 and above, have an increased risk of myocardial infarction at each of these different ages. There have been other studies showing maybe a 50% increase would be the hazard ratio. Over on the right, you can see many traditional risk factors that we're used to seeing, such as age, smoking, tobacco, hypertension, and diabetes. But on the top there, you can also see HIV infection itself in this particular study had an incidence rate ratio of a 20% increase in risk. Regarding the antiretroviral therapy choice, this was a study first presented at the CROI meeting in 2017 regarding protease inhibitors. And it really tried to answer the question of, there have been many protease inhibitors going all the way back to 1996, and some of them we know had adverse cardiovascular effects, mainly mediated through lipid panels. But when we reached sort of our last two protease inhibitors that were left, really atazanavir and darunavir, were there still these adverse cardiovascular effects associated with them? And this is from the DAD study, again, another large cohort. And it showed basically on the x-axis cumulative years of exposure, and on the y-axis here, cardiovascular incidence rate. And what they did in this trial was do a combined endpoint of myocardial infarction, stroke, or an invasive procedure such as angioplasty or carotid endarterectomy as their composite input. And this is listed in events per 1,000 person years. You can see at baseline there was an elevated risk here, 5 per 1,000 person years of follow-up, but it looked to increase through the years on the darunavir arm. On the univariate analysis, it does look like ritonavir boosted atazanavir did have some increase from that baseline of at year 0. But when the multivariate analysis was done, it looked like darunavir actually persisted in terms of adding an increased cardiovascular risk. Now, of course, this case involves a patient who smokes cigarettes. There's a couple of facts I want everybody to be aware of out there, which is that people living with HIV tend to have 2 to 3 times higher rates of smoking. And there have been a number of authors that have postulated why this might be. It could be a high rate of anxiety, other mental illnesses, higher rate of other illicit drug use and alcohol use, sociodemographic stressors, perhaps risk-taking behaviors and impulsiveness, or really a false perception of smoking risk. And I should say on a practical basis, if you can imagine being told that you have HIV or AIDS, for example, smoking cigarettes does not seem to be a relatively large problem. Many people, especially diagnosed in the early 80s, were essentially given a death sentence at the time. And so, the patient's attitude might be, why not? And perhaps because of that legacy, smoking cessation really is a low priority amongst HIV providers, considering that, CD4 and viral load being a little bit more important. I want to show now the link between smoking and myocardial infarction. This is a little bit of a complicated graph on the left, but it comes from the Danish HIV cohort study. And you have in different colors, as well as the solid versus the dashed lines here, cumulative incidence of myocardial infarction with it looks like 8 years follow-up total. And I want to show really, first of all, the striking differences just in the blue, the dark blue on the top, the medium colored blue, and the light blue on the bottom. These are all people living with HIV. On the top, you have current smokers. In the middle, previous smokers, and at the bottom, never smokers. So really a very obvious dose effect of tobacco use on myocardial infarction. And then if we compare the HIV positive individuals to their HIV negative counterparts, you can see really interesting differences between the two. And the brackets on the right, what we're showing here is that current smokers who are HIV positive have a much increased risk compared to current smokers who are HIV negative. And that actually, that trend holds for former smokers as well. These authors went on to calculate the population attributable fraction, which is to say that out of all the myocardial infarctions that do occur, how many of them actually were related to smoking cigarettes? On the left-hand side of the figure on the right, you can see those who had ever smoked, and then on the right, a counterfactual situation if they had stopped smoking. You can see very high proportions of the myocardial infarctions can be attributable to cigarette smoking, up to 72% in people living with HIV who had smoked. We move back to the DAD study and show, again, this kind of interesting dose effect where on the left-hand side, those who had never smoked being the standard here, and then previous smoking giving you an increased risk, and then the highest risk, of course, from current smokers. There's some good news on this slide, which shows that if you do stop smoking during follow-up in the DAD study, you can have a decrement in the risk of myocardial infarction attributable to tobacco smoke. Now we turn to a modeling study here, which is kind of going at the question of, well, what can we do about it? We know that cardiovascular risk is a multifactorial phenomenon related to lipids, related to blood pressure, as well as smoking. And this study tried to model the impact of different interventions on the cardiovascular risk. which you can see is the baseline situation with no change in the blue line. And the orange shows a blood pressure intervention, the green showing a cholesterol intervention, and the yellow showing smoking cessation. What's clearly indicated in this model is that smoking cessation alone has out of all of the different interventions, has the largest impact. Of course, in real life, we would probably want to do more than just one thing, but it's important to know what has the biggest impact. I want to show you one more slide just to show that, of course, the best is not just to do one thing. This particular study looked at individual interventions on their own, and then a joint intervention, of course, going after multiple of these risk factors. And when you combine things together, such as blood pressure control, reduction of lipids, as well as smoking cessation, that in the purple bar on the far right is going to have the largest reduction in cardiovascular disease cases. So best would be to do everything. It should be noted that modifying ART with respect to a cardiovascular risk outcome really hasn't been looked at in detail in prospective studies, especially registrational trials, which are probably too short to show that impact. And I think we should probably think about this in terms of modifying ART to intermediately affect things like lipids, which then, as we know, through ASCVD risk scores probably does impact cardiovascular risk in the long term. One slide just on smoking cessation. I think this is an important part of the toolkit for HIV providers. Cessation rates, as I mentioned earlier, tend to be very low when patients are not nudged, first of all, and when they attempt on their own. And unfortunately, people living with HIV and AIDS are less likely than the general population to successfully quit. One cross-sectional survey showed a 32% success rate compared to 51% in the general population. I have listed on the bottom here just a couple of the FDA-approved ways to assist in smoking cessation. Nicotine replacement with a duration of 8 to 24 weeks, not all that much data in people living with HIV. Varenicline, which is a nicotinic receptor, kind of a partial agonist with schemes going 12 to 24 weeks. Not great success rates, but it's better than nothing, 15% at 12 months with specific data in people living with HIV. And then bupropion, which is a norepi and a dopamine reuptake inhibitor, also limited data in people living with HIV, but about 20% success rate at a year follow-up in the general population. So to finish up this case, people living with HIV have an increased risk of multiple adverse cardiovascular outcomes versus the general population, including myocardial infarction, hypertension, and peripheral arterial disease. Interventions to reduce cardiovascular disease risk are often underutilized, and smoking, which does occur more frequently amongst people with HIV versus without HIV, dramatically increases cardiovascular risk. So smoking cessation really is one of the potentially highest impact interventions at reducing cardiovascular disease. And before I ask my colleague to just comment a little bit on this case, I also want to point out that we can't forget about our regular preventive health care. And if you notice, this particular patient had more than 30 pack years of smoking history, and according to U.S. Preventative Services Task Force, should also be getting chest CTs for surveillance. So Dan, any comments on the cardiovascular risk profile of this patient?
Well, just two brief comments. One, I think you point out how challenging it is to get people to stop smoking, and as you say, if at first you don't succeed, try again, because it may take multiple attempts. And it's really striking from the data you showed how little impact some of the newer interventions seem to have. You'd think there'd be much better success rates. The second important point you made was that we really don't have very much data about what is the reduction in risk associated with changing antiretroviral regimen. The only drug for which there's data that approaches that question is really abacavir from the DAD study, where it was really abacavir exposure within the most recent 6-month period, suggesting that prior exposure had less of an effect, whereas the newer data with darunavir are about cumulative exposure. So we really don't know how much of the risk is modified by switching, although if people with cardiovascular disease or at high risk for cardiovascular disease are on a regimen that has been associated with an increased risk of MI or stroke, it certainly makes sense to try to mitigate that risk while addressing the other important risk factors that are modifiable.
Great. Thanks for those comments. I would add that, we are a little bit hamstrung because most drugs get approved with relatively short follow-up in the registrational trials, and we have to rely on longer-term cohort studies to show some of these differences. And then one final clinical pearl I will say is that it really helps sometimes to calculate an ASCVD risk score, which has been shown in studies to perform relatively well in HIV-positive populations. And if you just tick the tobacco use yes or no, you can see dramatic changes in that risk. And sometimes that makes the light bulb go on above people's head to want to quit. Okay, so we're reaching the final case here. In our last 10 minutes, we'll go through mental health and neurocognitive disorders. Now, this case is relatively complicated. A 67-year-old MSM who's currently on a salvage regimen of dolutegravir, FTC and TAF, and darunavir cobicistat. He was diagnosed in the late 80s, had a long history of HIV disease. His nadir CD4 count was 125. Started dual NRTI therapy in the 90s, multiple regimens since then, has many complications of HIV, including zoster and pneumonia. And he presents to you with concerns of cognitive decline, increasing isolation, and depressive symptoms. He gives you examples of losing keys, forgetting where he's parked, and he finds himself sometimes walking into a room and forgetting what he's been doing. A lot of other medical history here. I don't think I have time to go through everything, but I will point out that he does have some recreational drug use, social alcohol, marijuana use. He has had a 10-pound weight loss, has some residual buccal fat wasting from his prior regimens. It's kind of a flat affect and poor eye contact. And then of his medications, several of these are psychoactive medications. So he's on gabapentin, probably for neuropathy. He's on an antidepressant. He's on a benzodiazepine, clonazepam for anxiety, a Z drug, zolpidem for insomnia. And his current labs look okay, a T cell count of 360 and an undetectable viral load, but with a PHQ-9 of 15. Just one slide on HIV-associated neurocognitive disorders, or HAND, which is really a spectrum of different disorders with variable prevalence in ART-treated individuals. The pie chart here shows a really interesting phenomenon, which is that in the pre-ART era, of these multiple diseases, HIV-associated dementia, or HAD, was relatively common here. It looks like almost 20%. And in the combination ART era, that's becoming much less prevalent. And it's being made up by these other disorders within HAND, and those would be called asymptomatic neurocognitive impairment, or ANI, and mild neurocognitive disorder, which may or may not be, the patient may or may not be aware of these things, especially in the asymptomatic purple side of the pie chart there. We have studied this through many cohorts, one of which is called the Charter cohort, which has revealed some aspects that are very important here. Risk factors we've seen are a nadir CD4 cell count below 200, advanced age, illicit drug use, hepatitis C co-infection, surprisingly, elevated cerebrovascular risk, sleep disorders, and psychiatric comorbidities. But I have to say the pathogenesis is really incompletely understood, making this really a challenging diagnosis to deal with and to manage. In terms of the management, there is a lot of overlap with other syndromes, such as polypharmacy, other non-HIV related causes of dementia, substance abuse can be involved here, and of course, depression can be a mimicker of some of these symptoms. Our tools for diagnosis are limited. I mentioned the MoCA, which is probably the best performing one, although there are several other dementia scores that you could consider. MoCA seems to perform the best. We don't have a real great evidence of treatment, evidence-based treatment guidelines. We've had inconsistent findings regarding changing the ART based on a CNS penetration effectiveness score. The toxicity actually might, if we choose a regimen that has a high penetration, there's been some concern that CNS toxicity from ART may actually be a problem here. So very complicated situation. The take-home messages here with this case are that neurological decline in aging patients with HIV is multifactorial and relatively prevalent. You saw almost 50% in that cohort. The clinical manifestations have really changed from a frank HIV-associated dementia more towards mild neurocognitive disease and asymptomatic neurocognitive impairment. And the clinical management really remains a challenge. We have to sort of all become better geriatricians. And of course, we need more research in this area.
Thank you very much, Dr. Kuritzkes and Dr. Reimers, and thanks to listeners for joining in. As a reminder, to view the full program, Confronting Real-World Challenges in HIV Care, and to download the slide set associated with this discussion on the Clinical Care Options website, please click on the links in the show notes. Thanks again.